installment of my Block 1 lecture series. We're going to finish up by talking about preoperative workup for patients. So just kind of going over some of the things we'll talk about in this section or in this topic: preoperative evaluation, cardiac risk, METs, ASA status. Talk a lot about medication management, specifically steroids, diabetes, and then also anticoagulation is in there as well. And then ending on some VTE prophylaxis, and then also preoperative antibiotics are in there as well. And this is Reese. This is my dog. And based on some chief feedback, we now have a white slide with black text and lots of pictures. So here you go, Mean Chief and Danny. Hopefully you like this one a little bit better than my previous presentations. So preoperative evaluation, all patients scheduled to undergo non-cardiac surgery should have an assessment of the risk of a cardiovascular perioperative event. And so anyone you're thinking about operating on, you should think about cardiovascular disease, weighing the risks and benefits of surgery, how do you optimize the timing of your surgery, and then also trying to uncover any undiagnosed problems are what you're looking for here. So in these patients, if you're sending them for a preoperative evaluation, this is what you expect either the medicine doc or the family practitioner or cardiologist, if that's who you're sending them to. These are some of the things that they are supposed to be looking at when they're doing this preoperative evaluation. So number one, of course, doing a complete history, and then specifically focusing on symptoms of angina, symptoms of dyspnea, syncope, palpitations. Also asking about history of heart disease, ischemia, valvular disease, cardiomyopathy, hypertension, diabetes, chronic kidney disease, peripheral artery disease, and cerebral vascular disease. So a lot of vascular cardiology things that you want them to be looking for in these patients, making sure that there aren't any misdiagnoses that haven't been uncovered yet. You'll also want them to discuss functional status and METs, and we'll talk about those a little bit later. And then also, hopefully you should be asking these questions, but they should as well in their preoperative workup, any previous issues with surgery or anesthesia, any sort of warning signs that you might be able to find of, hey, this patient might not do well with surgery or may need some extra help in the perioperative period. So also, of course, as part of your preoperative evaluation, the patient should have a complete physical done by the evaluating physician, specifically looking at blood pressure, heart and lung auscultation. Are there any sort of new murmurs that they're hearing or arrhythmias? Doing a general abdominal exam, looking for masses or pulsations, and also extremities, edema, vascular issues, things that might warn you, hey, this patient might have CHF or something else underlying going on as well. So pre-op testing in patients is usually performed to lower long-term risk and not for the desire to lower immediate risk. So if you're going to perform pre-op testing in this patient, it's usually because you're trying to catch this disease process early and to impact their lifetime, and not so much how you're going to impact lowering the risk or the immediate risk for surgery. So it's kind of more uncovering the problems and finding them, but a lot of times it's the benefit the patient actually receives is more of the long-term risk. Once the patient has CHF, you're not going to do a great job of decreasing their surgical risk just by diagnosing it, but hopefully they'll also make you a little bit more aware of underlying issues. So pre-op testing, pretty common, EKGs in patients. Most of the time it's recommended for patients with known cardiovascular disease. These can be obtained in asymptomatic patients, but it's not really helpful pre-op. If your patient's asymptomatic, you're most of the time not going to find anything. The rationale for most of the people obtaining preoperative EKGs in patients comes from the utility of having a baseline comparison should post-op issues arise. So in a lot of these healthy middle-aged patients, we're not getting EKGs because we expect to find something, but more of if something happens post-operatively, we have something to compare it to. Most of these cardiovascular, especially bodies, don't recommend further cardiac testing unless it's indicated in the absence of the proposed surgery. So would you get this test if the patient wasn't having surgery is kind of the thought process behind it. You don't need to go out of your way getting echoes or stress tests or anything else if the patient doesn't have an indication for it. If they're not having symptoms, if they don't have any other findings that make you concerned, you shouldn't just be getting echoes on every patient or stress tests. It's only if they have some other indication that warrants the testing. So very high risk patients, and these are patients that should probably see cardiology prior to surgery for optimization, not ones that you're just going to send over to the internal medicine or their PCP for preoperative evaluation, but any patient who's had a recent MI, unstable angina, decompensated heart failure, high-grade arrhythmias, or valvular heart disease, in particular aortic stenosis, those are patients that need to be seen by their cardiologist prior to any planned elective surgery. So there are a few risk models that are used, and I'll talk about both of these. There are many, many other risk models, but these are two of the more validated models. The Revised Cardiac Risk Index is a more simpler model, and it's widely used and validated, and it helps predict 30-day risk of death, MI, or cardiac arrest in patients. And then the American College of Surgeons, they have their National Safety Quality Improvement risk model. It's a little bit more complex. There's more data that goes into it that you have to put in as a physician, but it also gives you a little bit more information afterwards. So the first one is this Revised Cardiac Risk Index, and it looks at 6 independent predictors of major cardiac complications, so high-risk surgery, history of ischemia or heart disease, history of heart failure, history of cerebral vascular disease, diabetes requiring insulin, or preoperative chronic kidney disease with a creat greater than 2. If they don't have any risk factors, then their rate of cardiac death, non-fatal MI, or non-fatal cardiac arrest is kind of listed below. So with no risk factors, 0.4%. With one risk factor, 1%. And then if they have 3 or more of those above risk factors, their risk is about 5.4%. And then they also can talk about rate of MI, pulmonary edema, VFib, primary cardiac arrest, and complete heart block. And again, those listed at 3 or more factors, obviously the highest risk of 9.1%. So this is the NSQIP model of risk calculator. So as you can see, it asks for a lot more information. Wants to know age, sex of your patient, functional status, emergency, ASA class, which we'll talk about a little bit later, steroid use, ascites, sepsis, ventilator dependent, disseminated cancer. Obviously, you can go through and read all those, and then it also does a BMI calculation at the end. So you put in all of this for your patient, and what it spits out is something that looks like this. So this is actually my risk with all of my data that I put in, and then you also put in the procedure. So I put in, this is for laparoscopic appendectomy, just kind of young, healthy patient. Here's my risk compared to the average risk, and kind of the chance of the outcome is below average. Readmission rate only at 1.9% for myself versus overall for anyone is a higher 3% readmission rate, but it gives you a lot of these other, any complications, pneumonia, cardiac complications, surgical site infection, UTI. So you put in a little bit more information, but it also kind of gives you a little bit more with it as well. So those are two of the models that you can use to kind of estimate your risk in these patients. Obviously, with any emergent or urgent procedure, you kind of know ahead of time that they're at an increased risk for any complications. But obviously, if they need the procedure, then they need the procedure. So cardiac risk in patients with underlying cardiovascular disease, including peripheral artery disease or stroke, they have an increased risk of perioperative cardiac complications. And this is most likely due to predisposed to myocardial ischemia. So volume shifts associated with surgery, blood loss, increased demand on the heart, and also increased platelet reactivity in these patients put them at a higher risk for cardiac complications in the perioperative period, and just something to be aware of if your patient has any of these issues that you need to be concerned with these potential complications. And sorry, this one's kind of hard to read. This is from UpToDate if you want to go by and find it, but this is a stepwise approach to perioperative cardiac assessment for patients with disease. So is this an emergency? Yes. Then just proceed to surgery. You kind of bypass all the rest of this chart. And then the next kind of step down that I know you can't really read too well is there acute coronary syndrome? So yes. If yes, then evaluate and treat that prior to any sort of surgical intervention, because you're not going to do the patient any good if they're also having a heart attack at the same time. And then going down, looking at their estimated perioperative risk, and then you can kind of follow this down. Sorry, I know it's pretty difficult to read, but that's another one that's out there. So talking about METs, or metabolic equivalents, and so this is something we use in the preoperative workup to evaluate patients and their functional status. So 1 MET is equal to 3.5 milliliters of O2 uptake per kilogram per minute. So essentially it's resting oxygen uptake in a sitting position is what it is, as clearly Reese is demonstrating for us here. And so, like I said, it's used as an indicator of functional status for patients. So 1 MET is being able to essentially just take care of yourself, eat, dress, use the toilet. Being able to do any of those functions is equivalent to 1 MET. 4 METs is equivalent to walking up a flight of stairs or a hill, doing heavy housework like scrubbing floors or lifting or moving furniture, can be anywhere between 4 and 10 METs. And that's usually the marker of where you want your patients at prior to surgery. A lot of times 4 METs is the indicator we use, as this patient has a fairly decent ability to perform daily activities and may do okay with surgery. Greater than 10 METs is equal to strenuous sports like swimming, tennis, football, basketball, skiing, and those are your patients that you're even, I guess, less concerned with, or at least what was originally taught is you're less concerned with these patients with any cardiac risks. However, unfortunately, in 2018, there was a prospective cohort study that concluded that subjectively assessed preoperative functional capacity did not accurately identify patients with poor cardiopulmonary fitness or predict postoperative morbidity and mortality. So we've been using this, it seems like, as a long time to kind of predict these patients that may not do well with surgery based on their cardiopulmonary fitness. However, apparently we're not really doing all that great of a job at predicting this. And their concern is that their subjective assessment resulted in a substantial misclassification of high-risk patients as low risk. And so those are the ones that you're worried about, of these patients that should be high risk, but they were classified as low risk because maybe they can ski or do something else. But as we all know, those patients also have heart attacks as well. So it wasn't a great indicator, unfortunately, as we once thought, at least in this one study that was recently released. So another thing we kind of use looking at patients preoperatively and their physical status classification is the ASA status, or the American Society of Anesthesiologists. This is what you hear a lot of times in surgical timeouts. Anesthesia will say their ASA class as part of it. So ASA class 1 is obviously the best. It's a normal, healthy patient. It's most of us at this time, healthy, non-smoking, minimal or no alcohol use. So those are the young, healthy patients that you like to operate on, are usually ASA class 1. ASA class 2 is a patient with mild systemic disease without substantial functional limitation. So they may be a current smoker, social alcohol drinker, pregnancy, obesity, well-controlled diabetes, hypertension, or mild lung disease would make people fall into ASA class 2. ASA class 3 is a patient with severe systemic disease, and unfortunately it seems to be a lot of the patients that we end up operating on. I'll hear anesthesia called most patients at least in ASA class 2 or 3. They have substantial functional limitations, 1 or more moderate to severe diseases, poorly controlled diabetes or hypertension, COPD, morbid obesity, hepatitis, alcohol abuse, a pacemaker, reduced EF, end-stage renal disease, undergoing dialysis, so all of those, or recent history of MI, CVA, TIA, coronary artery disease, and stents. ASA class 4 is a patient with severe systemic disease that is a constant threat to life. So if they've had a recent MI, the other one was history of MI greater than 3 months. If they've had a recent MI, TIA, cerebral vascular accident, ongoing cardiac ischemia, severe valve dysfunction, severe reduction in EF, sepsis, DIC, ARDS, end-stage renal disease, not on dialysis yet at this point. Those are patients that are classified as an ASA class 4 and ones you're very concerned about if you have to operate on them. ASA class 5 is moribund patient who is not expected to survive without the patient. So these are patients that are going to die without operative intervention, ruptured AAA, massive trauma, intracranial bleeding with mass effect, ischemic bowel in the face of significant cardiac pathology or multiple organ system dysfunction. And then ASA class 6 is a patient who's declared brain dead and who we are operating on. His organs are being removed for donor purposes. So that's the only time you'll hear of an ASA class 6, but that's what that is. So like I said, most of our patients are ASA class 2, class 3. ASA class 1 is your really nice healthy patient without any issues. And then 4 being someone who has some very serious medical problems, and 5 is someone who needs surgery or is going to die. So moving on a little bit into preoperative medication management. This would just be a quick review of medications to start, stop, some things to think about when doing especially med recs on patients that we're admitting or who we think will probably end up requiring a operation during their admission. So first one starting out more cardiovascular medication, so beta blockers. These should be continued pre-op and throughout the hospital stay in patients who are already taking them. Do not start a beta blocker acutely during a pre-op phase. So if this patient's going to have surgery tomorrow and for whatever reason, someone thinks they need a beta blocker, it should not be started preoperatively on these patients. Same thing with alpha-2 agonists, so these are the patients on clonidine is the most common one I think we see around here. These should also be continued in the perioperative period, and once again, should not be initiated very shortly preoperatively. So if they're already on it, continue it. Do not start them on it prior to surgery. Calcium channel blockers, another one. These are ones that they recommend continuing in the perioperative period if patients are already taking them, but also being aware there is some conflicting data concerning increased risk of bleeding with calcium channel blockers. It's not very well proven, but just something to be aware of, that some of that literature is out there. ACEs and ARBs, this is a big one I think we see a lot of times. These are medications that are recommended to hold the morning of surgery. However, if the indication is heart failure or poorly controlled hypertension, they actually recommend continuing them to avoid exacerbation of the underlying problems. Now, I think that's kind of more evaluated on a case-by-case basis, and I think overwhelmingly we hold these pre-op and then restart antihypertensive medications post-operatively as kind of their blood pressure rebounds or kind of normalizes for them and they become hypertensive. Diuretics like hydrochlorothiazide, Lasix, if taking for hypertension, hold in the morning of surgery. If taking for CHF, you may want to continue them is kind of the suggestion given, depending on volume status. If this patient is significantly volume overloaded and they're undergoing surgery, maybe this is someone you would continue diuretics on, but I think probably unlikely. For the most part, we're going to be holding diuretics prior to surgery on most of our patients. Digoxin, especially for patients on heart failure, these should be continued. And then statins should also be continued. There is evidence that statins actually prevent postoperative vascular events. So should be sure to continue statins in patients who are already taking them. H2 blockers and PPI. These are medications that if they're patients on long-term, and actually a lot of our other patients we start on PPIs, they're severely ill, these should be continued. There are IV options to be aware of for these medications. If they're going to be NPO for a while, be sure to transition these medications to IV so that they continue receiving them. Inhaled beta agonists and anticholinergics, these are for your patients with COPD or asthma. Those medications you want to continue, especially if they're taking them every day. That's not a medication you want to stop preoperatively. Thyroid medications, both hyper and hypothyroid medications are encouraged to continue in the perioperative period. In the literature I was reading on UpToDate regarding this, they did mention some IV forms of some medications that are out there if the patient really needs it and is going to be NPO for a long time. So there are some other options on those as well. Psychotropic agents, so TCAs. If the surgery is urgent or emergent, just continue the medication. However, they suggest if this is going to be an elective planned procedure, discussion with whoever is prescribing the medication, whether it's psychologist or psychiatrist or internal medicine or family medicine, discussing with their providers and attempting to discontinue that medication, especially if they're only taking a low dose of it. Those medications can be harmful in the perioperative period, and so if you're able to, you should try and get them off of it. If it's at a much higher dose, or if the patient's at risk with severe depression, then they're okay with continuing those medications. SSRIs actually may increase bleeding risk, especially if they're taken with NSAIDs or antiplatelet agents. For most patients, however, they recommend continuing SSRIs. However, if they're very high bleeding risk or the planned elective procedure, if they are planning on undergoing an elective surgery on antiplatelet agents, consider stopping these medications, but it has to be done weeks prior to the procedure to decrease the bleeding risk. MAOIs, these have a risk for hypertensive crisis with anesthesia. And some of the medications that they use. So if at all possible, try and discontinue MAOIs preoperatively. This is another one that probably needs a few days at least of discontinuation prior to the procedure if you're able to. Just some other psych medications, lithium and valproate. These are used for more severe mental illnesses and should be continued. With lithium, especially, it requires increased attention to fluid and electrolyte monitoring, and you also want to check thyroid function prior to elective procedures because lithium can affect thyroid function as well. And antipsychotics, you want to try to continue these in patients who are at risk for psychosis. However, they also have a lot of other side effects, and so if you're able to get patients off of these medications prior to planned surgery, that is more ideal. Chronic opioid therapy, I included this as well, just because I know we have patients on naltrexone and other medications. If the patient is going to have an elective procedure, it's a discussion you need to have with the patient of probably trying to discontinue the naltrexone prior to elective procedures and starting them on multimodal pain control. And they also recommend that in the acute setting, just briefly post-op, it's okay to give these patients opiates for that severe post-op pain, but then trying to get them off of it as soon as possible, back to multimodal pain control, and then back on that naltrexone. So this can be a little bit more complicated and difficult to deal with and takes a lot more communication between the surgeon and the other medical providers taking care of this patient, especially those who are giving the patient naltrexone and monitoring their opiate use. Also to be a note, just one other thing on that, there are, I have run into it at least in the past, some programs or rehabs or whatnot that will test their patients for opiate medications. I've run into it, I think, with trauma patients before, and they get very nervous that they'll be kicked out of the program if they test positive for opiates, if we give them medications here in the hospital. And that's something just to discuss with the patient and also with their rehab providers. I had one patient who was very freaked out about it, but after discussing with the providers of the rehab facility, they said, no, of course, the patient had like multiple broken bones, I'm pretty sure. And they're okay with short-term opiate medications in these patients when the need truly arises. So also touching on some herbal medications here, pretty much you want to discontinue all of these. I think echinacea is one, and valerian, those bottom two, are ones that don't have as strong recommendations to discontinue. They don't have great evidence for them, but pretty much if they're on any sort of herbal medications, these should be stopped prior to planned surgery. Especially garlic, ginkgo, these can both cause increased bleeding risk. Ephedra has an increased risk of MI. Ginseng has the increased risk of hypoglycemia and bleeding risk. Kava kava has increased sedative effects. It has been associated with fatal hepatotoxicity in patients. St. John's wort interferes with your cytochrome P450 and interferes with drug metabolism. So a lot of these medications, for whatever reason the patient's taking, they have a lot of other important side effects that related to surgery that should be stopped preoperatively. So diabetic medications can be a little bit difficult in patients. This is a more generalized statement. Obviously, every patient's going to be a little bit different, but for the most part, I recommend stopping all home diabetes medications preoperatively, and especially patients who are admitted prior to their procedure or spending some time in the hospital before undergoing surgery. Start these patients on sliding scale subcutaneous insulin. And then post-op, when diet is more consistent with they're back on a diet or they're on TPN or tube feeds or whatever we're planning on doing, that's when it's safer to begin restarting home medications slowly as their either insulin requirements or medication requirements may have changed following surgery. So being very careful and starting slow and low on these diabetes medications when restarting them. Generally, if the patient's coming in for a planned outpatient procedure, the recommendation is that they do not take their morning doses of medications prior to surgery. So glucocorticoids, this is one that I think is a little bit difficult to deal with at times, so spent a little bit more time on this one. So for these patients, anyone on steroids, they kind of fall into two categories. Well, I guess there's three, but we'll get to that. Either they are at risk for a suppressed HPA axis or they're not. So patients who are likely not to have a suppressed HPA axis are patients who have taken steroids at any dose for less than 3 weeks. So if it's been less than 3 weeks, regardless of their dose they're on, they likely do not have a suppressed HPA axis. If they're on less than 5 milligrams a day for any duration of time, those are also patients that likely do not have a suppressed HPA axis. And then if they're on less than 10 milligrams for every other day, I don't really know what sort of regimen that would be or when people would get that, but that was included in here. Also patients not at risk for suppressed HPA axis. So in those patients, when you don't have this concern for suppression, you can continue the same regimen perioperatively. So you can just leave the patient on the medications that they're on if you're not planning on... so just leave them on the medications that they're on. For patients who are at risk for an suppressed HPA axis, so if they've been on more than 20 milligrams a day for longer than 3 weeks, or if they have a cushingoid appearance, these are patients that definitely have a suppressed HPA axis, or most likely, and so these are the patients that require perioperative steroid increases. And we'll kind of get to that dosing regimen here in a minute. So, of course, there's some wiggle room in between these two of more than 20 milligrams per day and less than 5 milligrams per day, and kind of what do you do with those patients in between. And so those are your intermediate patients. And Reese feels the same way I do about these of all of the other testing that's required. So these are patients with planned procedures. If they fall into this intermediate category, so they're not taking more than 20 milligrams per day or less than 5 milligrams per day, then you want to evaluate them for HPA axis suppression. So the first thing you do is an AM cortisol test. If their AM cortisol is less than 5 micrograms per deciliter, they have HPA axis suppression, and they're going to require additional steroids perioperatively. If their morning cortisol is greater than 10, they have no HPA axis suppression, and they do not require additional steroids. And of course, there's another intermediate category. So if they fall between this 5 and 10, then they need to undergo an ACTH stim test. And in doing that, the number is less than 18. If they're less than 18 at 30 minutes with the ACTH stim test, then they require additional steroids. So those are patients who have the HPA axis suppression. And in any patient undergoing urgent or emergent surgery, you should probably give them additional steroids perioperatively, because obviously you're not going to be able to do this HPA axis suppression testing. And so it's better to be safe and give them extra steroids perioperatively than be playing catch up and behind the 8 ball in these patients. So here are the recommendations for minor procedures, and they actually say inguinal hernia repair, kind of our patients who are in and out same day. Take their usual morning steroid dose, and then no extra supplementation is necessary. For moderate surgical procedures, take their usual morning steroid dose, and then these patients get 50 milligrams of hydrocortisone IV just prior to the procedure, and then 25 milligrams of hydrocortisone every 8 hours for 24 hours after, and then resume their normal dose after 24 hours. For patients going under major surgery, these are the patients that, again, they're going to take their usual morning steroid dose, and then you're going to give them more. So give them 500 milligrams of IV hydrocortisone prior to induction of anesthesia, and then 50 milligrams every 8 hours for 24 hours. And then you're going to taper dose by half per day to maintenance level. So if they're going up under much greater stressful surgery, they're going to require more steroids, and then you also have to do the taper with them. So anticoagulation in patients, I think this is another one that we see commonly pre-op, kind of what to do. So things to be aware of: dual antiplatelet therapy after drug-eluting stent placement. This is aspirin and Plavix most of the time. Uninterrupted therapy is recommended for anywhere between 6 to 12 months. There is some newer literature coming out that maybe 6 months is at 6 months they're okay. However, I would not stop anyone's dual antiplatelet therapy, likely without talking to their cardiologist or whoever the cardiologist is on call, covering for their physician, because like I said, the literature is kind of newer, and some are moving towards the 6 months, some are more still at the 12 months. So that's one to be aware of. If the patient is on one of the factor Xa inhibitors, Xarelto, Eliquis, Pradaxa, these need to be held 2 to 3 days prior to any planned procedure. So they have a little bit of a shorter time frame compared to what you'll see warfarin is at, and also the antiplatelet agents like Plavix are usually 5 days for most of our attendings. And then warfarin, just to kind of go through this one a little bit more, warfarin is recommended stopping at 5 days prior to any elective procedure. If you have to do emergent surgery on these patients, you do have some reversal options with warfarin. With the other ones, it's pretty much Kcentra is kind of your option there. But reversal here, so vitamin K, you can give IV 5 to 10 milligrams. Vitamin K has a sustained effect for many days, but it takes about 12 to 24 hours to begin effect. So it's not going to start right away. If this is a patient that you need to take urgently to the OR, if you're just giving them vitamin K, it's not really going to do anything for their INR over the next 1 to 2 hours. So those are patients you're going to need to give something else. However, if this is a patient that comes in the day prior and you're not planning on operating on them for about 24 hours, then vitamin K may be enough to get them through. Vitamin K is good for head bleeds or patients where they're going to need to be off their anticoagulation for a long period of time because, like I said above, it is sustained for many days. So it's not going to be as good for patients that you just want off of their warfarin for the surgery, and then we plan on putting them back on their warfarin as soon as possible post-op, because you're going to have a very hard time getting their warfarin up to therapeutic levels while they still have the vitamin K in their system. So it's something to be considered. I know pharmacy here has said things at times. They don't love vitamin K as much as some of our other options because of that. In some of these patients that we need to quickly restart anticoagulation post-op, it's really hard to get them back to therapeutic levels. FFP, or fresh frozen plasma, is your other option here. Usually, this is just based on information from UpToDate. It takes about 8 units to reverse someone. However, obviously, this is going to depend on the patient's INR and what their therapeutic levels are at. The cost is a little bit cheaper, as you'll see, compared below to Kcentra. It's only about $200 to $400. However, volume can be an issue with this. So it can be up to almost 2 liters of fluid that's required when you're transfusing the FFP to get their INR to normalize. So if these are patients with multiple underlying cardiovascular issues, you might not want to give them an extra 2 liters of fluid. So just something to think about. It also takes some time, so it takes about 30 minutes to thaw each unit of FFP, and then the effect only lasts a few hours. So this is much better for patients who are having that urgent or emergent surgery. It comes on quicker, but the effect only lasts a short time. So if you want a little bit longer of effect, a lot of times you can give this with vitamin K for that more sustained, long-lasting effect versus the FFP, which only gives you a few hours, and then their INR may continue to go back up. The last option, Kcentra, or PCC, contains factors 2, 7, 9, 10, and then variable amounts of protein C and S. They also talk about there are 2 different types of PCC. There's 4 factor and 3 factor. And that's just based on the level of 7, the amount of factor 7 that it has in it. So the 3-factor PCC has lower levels of factor 7 in it than does the 4-factor PCC, which has higher levels of factor 7. PCC works within about 10 minutes of infusion. And again, like FFP, the effect only lasts a few hours, so it's good for that immediate reversal. But if you want longer lasting, like in your head bleed patients, may need to be given with vitamin K. And of course, this lower volume comes at a higher cost. It's estimated anywhere between $1,000 and $2,000 for a unit of Kcentra. So a little bit more expensive for patients as well. And that was just one estimate. I know I've seen higher cost estimates for Kcentra. So next, moving on to VTE prophylaxis. Patients, this is something we discuss often and should be looking at every day on our patients. Are they on VTE prophylaxis? When should we be starting them? So going through, how do you calculate risk, of course, in VTE, as we see in a lot of these preoperative workups and perioperative time period. There are a lot of risk factor models. And so this is the Caprini risk model for VTE risk in general surgery patients. And so it goes by point-based system. And so just kind of looking at it, any sort of laparoscopic surgery greater than 45 minutes and age 61 to 74, usually those 2 will get our patients into at least the moderate risk for most of the surgeries, or at least even major open surgery or kind of a longer laparoscopic surgery at a younger age will still put them into moderate risk period. So for the most part, anyone we're operating on is going to fall into this moderate risk category. We aren't going to have a lot of low risk patients unless they're just here for a small bowel obstruction, they're not having surgery, and then they go home. Those might be the few patients that we have kind of in the lower risk portion of this. So just looking at it, obviously moderate risk is anywhere if you get 3 to 4 points. So laparoscopic surgery and age in most of our patients is going to put them at 3 points just right off the bat. And so they fall into this moderate risk as well. Their estimated risk of venous thromboembolism in the absence of prophylaxis is 3%, which is pretty high risk in those patients, some things we definitely want to take steps to avoid. And so kind of how do you help do this in these patients, or how do you prevent VTE in these patients? So in the low risk patients, if anyone follows at least in the very low risk, which is pretty much none of our patients, and then in the low risk, they say you can advocate for early ambulation, mechanical support, so that's SCDs that we have here, those little squeezy boots on their legs and feet, and then having them get up and walk around and not be laying in bed all the time may be enough. But like I said, for the most part, most of our patients fall into that moderate to high risk category, and so most of our patients require pharmacologic assistance with VTE prophylaxis. So you have a few options for these patients. Low molecular weight heparin, or Lovenox, is the one that we use, I think, most often. It's something to consider if you have a much older patient or those with known kidney disease. Lovenox does have some renal toxicity, and so this might not be the correct patient population for Lovenox. However, the rest of our patients, the dose is usually 40 milligrams once daily sub-Q. If the patient is really high risk, they could say you can give it up to 3 times a day. But usually I've only seen BID dosing kind of at max for these patients. The other option is unfractionated heparin, so not good in patients with known liver diseases, probably better to use Lovenox in these patients, but you can use the unfractionated sub-Q heparin in patients with known kidney disease, and might be a little bit better in some of your older patients. And so the dose of sub-Q heparin is 5,000 units Q12, so it means patients get more shots per day. They get 2 instead of 1 with the once daily Lovenox. And if patients are really high risk, you can give it every 8 hours. Unfortunately, heparin is usually weight-based dosing. However, at least in the up-to-date article that I pulled this from, ideal dosing for obese patients is unknown, and they state that you can give up to 7,500 units every 8 hours in these obese patients who are very high risk for VTEs. Your last option here is fondaparinux. This is essentially used in a very small group of patients in whom HIT is suspected, so you can develop HIT with either heparin or Lovenox. Although the risk is pretty small with Lovenox, it is possible. So if you have a patient and where HIT is suspected, if they have a dropping platelet count, we usually send off a HIT panel, but that takes many days. And so what we do in the meantime, while waiting on that HIT panel to come back, we obviously stop the heparin drugs in these patients and then switch them to fondaparinux. And this is given at 2.5 milligrams once daily. So not given as often, but it is kind of your third option in these patients if you need it. And then just going through preoperative antibiotics in these patients, there is a chapter on the website that I would encourage you to look through. It has a little bit of extra information than what I went in here, especially on some of the operative and preoperative things, especially it does a little bit more on preoperative antibiotics and cleaning methods and clean closure and those sort of details. But just to go through here, just some basics. And preoperative antibiotics should be administered within 60 minutes of incision, and actually 120 minutes for vancomycin and fluoroquinolone, so those need a little bit longer infusion times preoperatively. And then this is just a chart going through. It covers most of the basic procedures we do. So any open biliary tract procedure, cefazolin or cefotetan. I do not believe we have cefoxitin, I think, but I might be wrong on that one. Elective low-risk laparoscopic procedures might actually not need any antibiotics according to this chart. However, I think most of the time our patients get ANSEF. Patients undergoing appendectomy for uncomplicated appendicitis, those patients usually get cefotetan pre-op. Any small intestine and obstructed patient, so if you're going in for a small bowel obstruction that didn't resolve with non-operative management, they need cefazolin and Flagyl for that anaerobic coverage. And then for any patient essentially with a beta-lactam allergy, a penicillin allergy, you're pretty much going to give them Clinda or Vanc, and then possibly an aminoglycoside. So just kind of some of those preoperative antibiotic regimens to be aware of. We do have some preoperative antibiotic power plans that are available in Power Chart that you can look through, and it kind of goes through the different indications on those. It makes it pretty easy to pick out. And if you haven't fallen asleep yet, now you can, because that is the end of my last lecture. So thanks for sticking through this, everyone.